Hi, good afternoon. Can everybody hear me okay? Yeah, great. So I'm Joseph Clift. I work at CMS. I'm in the Division of Quality Measurement, and my division had the contract to develop the Experience of Care survey. We developed one for the LTCH setting and one for the IRF setting. They were developed at the same time, so I'm going to talk about the LTCH work that we did. So this was a contract that Research Triangle Institute had to develop the Experience of Care survey. They developed the survey over about a 2-year period, which concluded in February of this year. So the development of the survey, I'm sorry, I'm supposed to do this. Okay, sorry. So RTI developed the survey, again, over a 2-year period, included a bunch of different phases. One was the information gathering phase, conducted testing of the survey, which was included both the field test and the mode experiment, and I'll get into those a little bit. And this survey allowed for the use of a proxy, which was something new for the surveys that CMS and CAP surveys in general have allowed, and I'll get into that a little bit. And the contract ended this February, and we have completed a English version and a Spanish version of the survey with the patient, the mode adjustment, and the patient mix adjustment for the survey as well. So the information gathering phase of this survey was through the fall of 2015 through about the summer of 2016. And in this, we followed the Agency for Healthcare Research and Quality's Consumer Assessment of Healthcare Providers and Systems, CAPS, Guide for Survey Development. So while this survey is not a CAP survey, we follow the CAPS principles for survey development. And we also follow the CMS blueprint for measure development. I'm not sure how many in this room are familiar with that, but it's a guide that CMS puts out about how measures should be developed for use in CMS's programs. So the first part of the survey development consisted of a public call for measures and survey-related items, survey questions, survey-based measures. We put that call out in the Federal Register. We also conducted a literature review and environmental scan to see what was out there specifically for these post-acute care settings, because there was no standardized survey in the public domain for these post-acute care settings, which is why we went ahead and developed this survey. We also conducted focus groups and interviews with patients, family members, and caregivers, and established a technical expert panel consisting of healthcare providers, researchers, patients, and patient advocacy organizations. And we also conducted cognitive interviewing. So kind of the totality of these efforts are what informed the questionnaire, the questions on the survey. So a high-level overview of the survey. The questions focus on these specific areas, and these all came from the literature. These came from discussing with researchers. These came from discussing with patients and family members of what is important to the patient, the family, the caregiver in assessing the experience that of care that they received. So the questions focus on goal setting and monitoring, care received from doctors, nurses, therapists, and all staff, thinking of all staff together. The experience at the LTAC and also the environment of the LTAC. Discharge preparedness and then questions getting at an overall rating, which is sort of standard on a lot of surveys, kind of overall, what did you think of your stay? What did you think of this place? And then we also have questions on the demographics of the patient and demographics on the proxy. So for the survey testing, two main testing that was done. One is the field test, and this is the first testing that's done after the survey is developed, where we're looking to conduct a psychometric analysis to test the reliability and validity of the survey items. And basically what we're trying to do is just make sure the survey is assessing what we're intending it to assess. Evaluate the level of agreement between respondent types, patients, and their family member or caregiver. To test the consistency of the survey items, and to evaluate the impact of different modes of survey administration. And for the field test for the LTCH setting, we tested in-facility mail with telephone follow-up. And the reason why we did in-facility is when we were recruiting LTCHs to participate in the field tests, many had already a survey in place at their hospital, and in-facility mode was one of the methods that they used to administer that survey. And this was a kind of a new mode for CMS for our surveys. A lot of them are mail or telephone surveys, so this was a new way for us to test one of our surveys, giving that survey out at discharge. So that was one of the modes that we tested. For the mode experiment, the aim for a mode experiment is, I should backtrack for a second. After the field test, what we do is, after we run the psychometric analyses, then we're developing those survey-based measures, those sort of like compressing the questions into certain groups of measures that we're looking at, and I'll get to. So that's where that information comes from, the field test, and then we take that and then we test it in the mode experiment. And the mode experiment aim is to test the survey procedures. So how is this, if you were doing this survey for real, how are those procedures being done in the facility? Validate the composite structure developed after the field test. So those are to validate those survey-based measures that we developed after the field test. We're validating that those are appropriate based on the results from the mode experiment. And you also use that information to develop the final model for the patient mix adjustment, which is if you have patients that maybe there's the differences between how maybe someone of a certain age group responds differently than someone of another age group, or sex differences, et cetera. These all can be part of the patient mix adjustment that you do on a survey. In addition, we also look at whether or not there is any adjustment that needs to be made when you're evaluating the results of the survey based on the mode of administration. So are there differences between how people took the survey if they were given it in the facility versus on the telephone versus if the survey was mailed? And then what you're doing is you're basically trying to make it equitable and creating a factor that you would use when you're analyzing the survey to just sort of level the playing field for that for those surveys administered at that hospital. So all of this was done for the survey testing. And for the field test, that was done during November 2016 through January of 2017. And that one, we were only able to recruit 12 LTCHs for that field test. So when we got to the mode experiment, we had to really sort of quadruple our efforts to recruit a large enough sample so that we could run the statistical test we needed to assess the reliability and validity of the survey. So for the mode experiment, we actually were able to recruit 69 LTCHs and get enough surveys back so that we could run the necessary tests on the survey to develop the patient and mode adjustment model that was necessary. So for the mode experiment, we ended up getting 1,364 completed surveys compared to 176 for the field test. And for many LTCHs, I mentioned the in-facility. So after the mode experiment, we decided that the in-facility was an appropriate mode for giving out the survey at LTCHs. And we kept that as one of the 3 modes for LTCHs to administer this survey. And for recruitment, a lot of LTCHs, if we weren't allowing an in-facility administration, they weren't going to participate because they wanted to be able to integrate this survey within their existing workflow, which often included administering a survey at discharge about that patient or their family or caregiver's experience. So for the final survey, the 3 modes are mail with telephone follow-up, and in-facility. So the survey items, so there's a whole list of, I can't remember the exact number, it's like 42, 46 like core questions, and there's the patient demographic questions. So all of those questions compress into 4 domains and 2 global ratings. So the 4 domains are goal setting and monitoring, communication with staff at the LTAC, I have a typo there, experience at the LTAC, and preparing for leaving the LTAC. The 2 overall ratings are considering everything, how would you rate this LTAC, and then considering everything, what's your likelihood of recommending this LTAC? So again, all of those questions, when you're scoring it, are compressed into these 4 domains and these 2 global ratings. And these are the survey-based measures that I was referring to. And I just want to spend a second talking about the proxy. So because the LTAC, the number of LTACs and patients served is a lot smaller than like acute care hospitals that use the hospital caps, which many people are probably familiar with. So that type of survey, that survey does not allow for a proxy. There's such a large number of patients that you can, I want to say ignore the ones that could not respond, but statistically you can sort of ignore those numbers and still have a statistically valid survey. But for LTACs there and IRFs also, there is a large number of patients that could not respond on their own due to some sort of physical impairment or their illness. So that number was too large for us to not be able to include within the survey. So for this, we developed a proxy response, which is someone familiar, a family member, a caregiver, familiar with that patient's stay, could answer the survey on behalf of the patient. And to develop this, what we did is we conducted a test of patient proxy pairs. So what that means is we recruited patients who were able to take the survey and also a family member or caregiver that was knowledgeable about that patient's stay. And we had each of them take the survey, and then we compared their responses to see how similar they were. So what we found was that a family member or caregiver that is familiar with the patient's stay provides similar answers to that able-bodied patient who could respond to that survey. And that was one of the key factors that allowed us to have the proxy be an appropriate respondent to the survey. And if you're familiar with other CAP surveys, you won't see that. That actually is one of the reasons why this survey is not a CAP survey. Because the CAPS Consortium, their surveys, they don't allow proxy responses. and we felt that it was necessary for this community, and also for the IRF community as well, has similar experiences with a large number of patients who could not take the survey on their own. So then you miss that whole, maybe 10 to sometimes 30% of your patients may not be able to take that survey or remember key aspects of the beginning part of their hospital stay, where you're getting into the goal monitoring and that sort of thing. And these are key areas of the survey that we wanted to be able to assess a patient's experience. And across almost all domains, there's one area where the domain for the reliability is a little low, but across almost all domains, there's a relatively high level of reliability. On the survey, the one area that's just slightly less, and when I say slightly less, a Cronbach's alpha of 0.8 indicates good reliability, and this one item is 0.78, and that is if a patient is, one of the discharge questions is if the patient was discharged with medication, there's an additional question about that medication. So that one was a little bit lower, but the overall survey is 0.96, indicating high levels of reliability. So this survey is measuring what it's intended to measure, and it's intended to measure in these 4 domains and the 2 global ratings that we saw that we developed the survey. So this is my last slide, and then we can see if there's any questions, but at this time, CMS is not going to propose the survey for use in the LTCH Quality Reporting Program. The survey and the related items, because we did not want to develop this survey and just sort of have it sit and collect dust. So this survey and the survey items, so the cover letters, the Spanish version of the survey, the in-facility version of the survey, the script for telephone interviewing, all of that information is on this website here. The CMS website for the LTCH Quality Reporting Program, and then there's a link for the Experience of Care survey. So if a LTCH wants to use this survey, it's in the public domain. They can use this survey as they see fit. They can use whatever questions they want on there. They can use it as is. They can append it to existing questions they have. Because we're not proposing this survey for use in the quality reporting program at this time, CMS can only answer basic questions about the survey. So an LTCH that wants to use it, they have to administer it on their own. They have to, if they contract with a vendor, they have to do that on their own. They have to, deal with analyzing the data, applying the patient mix adjustment, et cetera, on their own. CMS will not be doing that, and we want to make sure that CMS does not receive any survey data, because we're not able to receive that because it's not it's not going to be proposed for the program. But there's just basic questions that a facility has about the survey. There is a email on this website that they can use to ask some basic questions. Of course, if a question was asked and we can't answer it, we'll certainly reply back. But we wanted to make sure that all the survey work that we did was available for LTCHs to use. I know a lot pay vendors. Some pay them a fee to use their proprietary survey instrument. So this is a standardized survey developed specifically for this post-acute care setting. I know a lot of LTCHs use the hospital CAPS, which was not developed for this specific setting. It was not developed for these patients in mind, and this survey was, so this is available for you to use if you would like. So that's all that I wanted to share about the survey. I guess if anybody has any questions, I'm happy to answer any. No? Excellent. Well, thank you very much for your time. The question is, why did CMS decide not to use it? So at this time, we are focusing our efforts to reduce burden, and I try to get to more meaningful measures and get like a more parsimonious set of measures for our different programs. And at this time, we felt that the survey itself was burdensome, and that's sort of where we where we ended up with that. But wanted to at least have it available for LTCH to use if they wanted to.
Mode of survey administration.
Oh, so the mode that we got, the highest scores actually came from the in-facility, and that was actually the one where we had the most just overall response in general. But the procedures that were developed for the in-facility, the LTACs received a lockbox so that patients could, if they wanted to, fill it out while they were getting discharged and then drop it in a lockbox. So the procedures made sure that the survey was not given to maybe the nurse doing the discharge or given to another staff member. They were asked to not be in the, like, hovering over them while they're doing the survey. So we developed these procedures that if the survey is administered in facility, that you do these X, Y, and Z to help reduce bias. But also there was also a lot of in-facility surveys that came back through the mail. So every survey came with an envelope that they could mail it back to RTI, who did the analysis on that.
Thank you.
Great, thank you very much.
Thank you.